So once we decided what type of retention you're dealing with, acute or chronic, treatment, as I said, is essentially the same. It's catheterization, either ureterally or suprapubic catheter. So you all know the technique of catheterization. Slightly different in males and females, essentially for the position and also because of the anatomy. The technique is given here. The only thing I would add to this is that make sure you maintain a good traction on the penis to straighten the urethra. There are two areas of curvature, which is usually the penobulbar junction and the bulbomembranous junction of the proximal bulbar urethra. So those are the most common sites of injury. Also, you do a catheter in males, and the way you can avoid it is by using adequate lubrication with jelly, lignocaine jelly, and make sure you use good traction initially vertical 90 degree. So it has to be initially vertical, perpendicular to the patient to negotiate the bend in the penobulbar junction. Then once you get about 10 to 15 centimeters of the catheter in, traction should then be changed towards the foot end, parallel to the body, to then straighten out the proximal curvature. That reduces the risk of injury. And catheter should be fully in, so the balloon port should be at the level of the meatus, and urine should be draining before you inflate the balloon. So those are the two things you have to check before you inflate the balloon. And that is right, you can either irrigate the catheter with sterile water, you can use what's called as a catheter tip syringe, you can aspirate with the 10 ml syringe, but as long as you get urine or some suprapubic pressure, all of these work, but make sure you get urine before you inflate the balloon. Females, it's a lot simpler, as long as you get the position right, which is supine, frog-leg position. If in case of difficult anatomy, where you're dealing with patients with a very high BMI, who are not able to get into a very good position, you can also do it with them in lateral position, and sometimes so making them to squat helps delineate the anatomy better. This is for difficult catheters. And then same thing, lubricate the catheter with sterile lubricant, or you can also put some anesthetic jelly, lignocaine jelly, but we generally tend not to. The width of the urethra and the length of the urethra. Catheterization in children is slightly difficult, mainly because they contract the sphincter, and you essentially wait for and the child will probably be crying, and you wait for the sphincter to relax in between the episodes of crying to then negotiate past it, but procedure itself is essentially the same. Absolute contraindication, these are all self-explanatory, where you know that they've got a urethral injury, especially pelvic fracture, where you know that they've got a urethral injury. They've had a previous history of bladder neck closure repair. Again, it's not a contraindication, it's just that it's a contraindication to be done by a very junior person. You should call should be done by competent people, will generally be the urologists. So what are the causes for failed catheter? One is lack of anesthesia. So it basically means the sphincter is really tight because of the pain. What you do, you ask them to cough, you ask them to try and relax the sphincter, which can be asking them to pass urine, take deep breaths. You're usually able to get past the sphincter, traumatization of the urethra, or what's more commonly called as causing a false passage. As I said, it's usually at the level of the penobulbar junction or at the proximal bulb. Bulbar urethra or the bulbomembranous junction. Once it happens, it's a flap gets raised, and no matter how hard you get a catheter in, try to get a catheter in, how much of an expert you may be, preferentially goes into the false passage. You will then need to negotiate what you can use. This is what's called as a crudative catheter, because the injury is most commonly in the posterior wall. And with the crudative catheter that is directed anteriorly, you may be able to sometimes negotiate the false passage. But otherwise, you might need a cystoscopy and pass a catheter in. If it's a urethral stricture, you cannot get a catheter in. If the patient's in acute retention and is screaming the place down, it might be more. You've got two options essentially with the urethral stricture. You can do a flexible cystoscopy and you can dilate, or you can place an SPC. It depends on how comfortable the patient is. If he's really uncomfortable, doing a flexible cystoscopy and dilating, it's going to cause more discomfort, cause a lot more pain. Maybe easier to just do a suprapubic catheter and manage it. And also, if it's a very long segment stricture, you're not going to be able to dilate it very well. Large prostatic middle lobe, what essentially happens is that you've got a bend just at the bladder neck where the catheter can't climb over. Couple of things you can do: use lots of jelly. Your catheter essentially floats on top of the jelly into the bladder, which pulls in the prostatic urethra. Or again, you can use what's called a crudative catheter, which doesn't poke. So essentially, if that's the bladder opening, you've got median lobe here, and what you need is a catheter that's got a curved tip. This doesn't poke into this tissue, but it just glides over it and into the bladder. The other alternative is you can use a cystoscopy to do it. So what do you do? Again, when someone calls you when you're a urology postgraduate, and someone says, I can't pass a catheter, the first thing you ask is, where is the problem? That helps you sort of troubleshoot. If they say it's at the meatus, I'm not able to get into the meatus at all, it can either be phimosis or it can be meatus stenosis. If they say that I'm able to get the catheter in about 10 to 15 centimeters, and then there's resistance with bleeding, it can either be a stricture or a false passage. And the last is if they say I can almost get the catheter in, but no urine drains out, then that means it's probably at the level of the prostate. So that means it's probably at the level of the prostate, or they've made a very big false passage, and the catheter is just undermining somewhere into the pelvis. So now you know where the problem is. If you think it's a prostatic obstruction, then try to get an 18 French or 16 French crudative catheter, which is the one that has a curved tip, and always keep the curve pointing up with it. And if we're able to, and about 80 to 90% of the times, if it's just a prostatic obstruction, you will be able to get it through with the crudative catheter. The percentages are just random. That's just from personal experience. I've hardly ever had to do a cystoscopy for a prostatic obstruction. So if it fails, you do a cystoscopy. It could be one of two things: either that your diagnosis that it was a prostatic obstruction was wrong, which I said could be because the big stricture, which they've made a big false passage, what you do is you place try and find the lumen, which is usually on the, so if that's the lumen and you can't see anything, false passage is usually on the floor. So try and find the lumen in this region between 9 to 3 o'clock, 9, 12, and 3. That's the area where you have to look for your actual vitral lumen, pass a guide wire through, and these people will be in retention. If you're able to get good amounts of the guide wire through into the past that area, it usually goes into the bladder, and then you place a council tip catheter. If it's a stricture, you may have to dilate. There are several dilators that you can use to dilate over a guide wire. So let's get cleared up a little bit. So now if you think the problem is somewhere more distal, phimosis, meatal stenosis, or a urethral, and you know it's could be a stricture, try and pass a smaller diameter catheter, usually attempt with the 14, so you can go with the 12. Anything less than that, it's not going to drain very well, it's going to get blocked, so you might as well treat the problem or place a suprapubic catheter in. What you can do if it's just a false passage, what we do sometimes is just pass a glide wire, which is just a hydrophilic wire, which becomes, it's really slippy and just tries to find its way wherever the water is or wherever there's a lumen, it'll try and go through that preferentially rather than go into a false passage. If you're able to get most of the guide wire in, that means you are in the bladder, the catheter will not randomly coil anywhere into the pelvis, or once it goes through an injury through the false passage. So if that is successful, then place either a 5-French catheter, or what we commonly use is a ureteric catheter, or any narrow catheter. You can, what this helps is once you do that, you can also aspirate and confirm that you're in the bladder, you'll get some urine, and then you can exchange it to a stiff wire and then advance the catheter. We generally tend not to bother with it. You can pass the catheter really comfortably over a hydrophilic catheter as well. You don't need to always change to a different wire. And if you can't do that, flexible cystoscopy will always tell you what to do. You can easily find. We don't generally tend to do rigid cystoscopies. What you can do with the rigid cystoscopy can be done a lot with the same amount of precision with the flexible cystoscopy as well. So I know that your notes say Bailey plan of action is if you fail catheterization, go with the suprapubic catheter, but that is, I feel, is historical. It would be wrong to place a suprapubic catheter for just a small passage. We always do a flexible cystoscopy if we find that it's a really bad or very tight urethra, then we do a suprapubic sometimes, or when the patient's really uncomfortable, really old, or it's got lots of other medical problems, we sometimes do, but the algorithm would be catheter. If it's failed, flexible cystoscopy. If that fails because you're not able to find the lumen, it's got a very long SBC, and preferentially it should be done under ultrasound guidance. This gives the lowest, reduce the chance of bowel injury, which if they are in retention, if you don't have ultrasound, always aspirate urine, and wherever you should be able to aspirate urine at least 2 finger breadths above the site of SPC. So if that's the umbilicus, normally you do it about 2 finger breadths above pubic symphysis. That's the midline, so that's the usual landmark. What we generally take as a rule of thumb is to go 2 finger breadths above that, place a small needle, and see if you can aspirate urine. If you're able to aspirate urine above that, it generally means that the dome of the bladder is higher, which means you're going into the anterior wall of the bladder, which is a safer place to do the suprapubic catheter. So you see, catheterization is not a very simple topic. You can talk for hours on top of it. BPH, on the other hand, so you're going into next, is quite a simple topic, at least from a management point of view or decision-making point of view. And for MCQs, you would basically be on the pharmacology of treatment, types of surgery, indication for surgery. So these are the things you need to be concentrating on. These are things that are most commonly going to be asked from BPH. So there are two components to BPH. So there it is. So BPH is an enlargement of the transitional zone. It grows into the prostatic urethra. It goes as the median lobe into the bladder. So that is essentially its transitional zone enlargement. That is BPH. So this is called two components to it: smooth muscle component and the stromal component. The smooth muscle component is what is seen here, is causes a dynamic increase, and that is the smooth muscle component is the one that responds to your alpha blockade. Then you have the stromal component, which is under the influence of androgens and estrogens, which is what you try and tackle with 5-alpha reductase inhibitors. So that's the gist of how you manage it. And most abundant in alpha 1A, alpha 1B, and alpha 1D are the different types of alpha 1 subtypes of alpha 1 receptors. Alpha 1A is the most common or the most abundant subtype. So that's what we said: stromal and epithelial components. 70% of men can have BPH, and it's one of the commonest problems that you deal with. So how do you find out how severe the BPH is? So BPH is an anatomical diagnosis. It's an anatomical. Sorry, something opening on my computer randomly. It's an anatomical diagnosis. It's not or you can say pathological diagnosis. It's not. So any man above the age of 60 will have some degree of prostatic hyperplasia. The decision to treat is based on symptom severity, or what we call as bothersome or bother that the symptoms cause them, and also other factors like complications of BPH. So that's what determines which patient needs to be treated and which patient can be managed medically or can be managed without any treatment. So one of the tools that we use is the IPSS score, which is the AUA symptom index, the International Prostate Symptom Score. So I've got that here. Hope you can all see it. So it's basically got 6 questions. The mnemonic to remember that is what's written here: fun and piss, frequency, urgency, and nocturia. So this are what called as the storage symptoms. And the rest of the piss: through a stream, intermittency, sense of incomplete voiding and straining. That are questions on the voiding symptoms. And it also has a quality of life question. So if your frequency, urgency, and nocturia, so that's fun, and poor stream, intermittency, straining, sense of incomplete evacuation. It also has what's called as a quality of life symptom, which is graded from 1 to 6. So it's 0 to 35. So 0 to 7 is mildly symptomatic, 8 to 19 is moderately symptomatic, and 20 to 35 is severely symptomatic. So it is one of the tools, and this is both a useful tool for, it's not a diagnostic tool. It's very good to measure treatment effects, but you cannot just use just this score to determine whether a patient needs treatment or not. As I said, it's not a diagnostic tool. It doesn't establish a diagnosis. Then you have what's called as frequency volume diary. It's more, as it says here, for storage LUTs, which is frequency, urgency, and nocturia, or overactive bladder. But it gives an idea as to of the nocturia element to basically differentiates between nocturia and nocturnal polyuria. That's the other thing we can see is the physiological bladder capacity. So that's what it's useful for. So what it looks like essentially this. So it's got times, you write the type of fluids, say coffee, set 300 ml of coffee, and then he pees voids about 150 ml, and they record. So you just record everything over 3 days, 3 random days, which are supposed to mimic your normal routine. And then we take that information and then we run. Again, it's not a diagnostic tool, it's just to give us more information on to help plan management. Again, severity of LUTs definitely has a negative impact on sexual activity. Hence, the use of PDE5 inhibitors. The only thing licensed for this at the moment is tadalafil, where you can use ardanafil as well. So these are the 2 drugs that are used. They can be used for, and they treat both erectile dysfunction or sexual dysfunction and low urinary tract symptoms as well. So DRE is a smooth enlargement of prostate, no nodules. Again, you can have nodular enlargement from BPH. And nodular prostate doesn't always necessarily mean prostate cancer, but rather than complicate the discussion now, it's a smooth enlargement of the prostate. You can reasonably estimate prostate volume with the DRE, but it doesn't always reflect the size of the prostate, because what you're essentially estimating with the DRE is the peripheral zone, and the enlargement is essentially of the transitional zone. So you may grossly underestimate the size of the prostate by just a DRE. Again, these investigations are not done routinely. At least ultrasound and serum creatinine not done routinely unless you suspect any reason for them to have renal dysfunction. We generally measure uroflowmetry and measure their post-ward residual volumes, again, because it's a good tool to monitor effects of treatment, especially if you're starting them on medical management. An acceptable post-ward residual is less than 30 ml, and a single post-ward residual, which is very high, should not place a lot of reliance on that. It's usually done, if it's high, once try and bring them back and check it again, usually a few readings to sort of establish an average. If it's more than 50 ml, these patients needs to be monitored. If it's persistently over 300 ml, then these patients need some form of catheter. They don't necessarily need some form of treatment, sorry. They don't necessarily need to be catheterized immediately, but they will need some form of treatment sooner rather than later, because these patients can go into high pressure chronic retention or just simple chronic retention. The gold standard for measuring the PVR is you put a catheter in, see how much urine comes out, and then you measure the volume of that. Not very practical, so what we usually use is ultrasound. So as I said, DRE is not a very good estimation of the prostate volume. So what can you use? You can use TRUST. Gives a very good estimation of prostate size. Nowadays, most of these patients who come in with the enlarged prostate, they will also have a PSA, which will many times be above it'll be above the cutoff. So they end up having MRIs. At least that's the practice here in the UK, where we practice a MRI first policy for anyone who's suspected to have prostate cancer, just essentially anyone with the raised PSA. So, and most patients, and use the PIRATS system to determine what's going on in their prostate. We'll talk a bit about it in the prostate cancer topic, but what that essentially does is the MRI gives a good estimate of the prostate volume and helps plan management. Again, PSA testing, it's a very, very controversial topic. It is not always recommended that you do a PSA. It will not change how you manage. But certainly, if you suspect them to have prostate cancer, if you've got a DRE, which is hard and nodular, and they are in retention, then yes, you will need to do a PSA. If they've got a completely benign feeling prostate, there's no reason for you to suspect. You don't always necessarily have to do a PSA, but we generally end up doing PSA in most patients anyway. So urodynamic studies. So these are invasive pressure flow studies, not just your simple uroflowmetry. Invasive pressure flow studies where you've got a catheter going into your bladder, a catheter going into your rectum, and you assess. And the whole concept of this is to determine whether the urinary retention is secondary to bladder outlet obstruction or due to detrusor failure. So that is the whole reason behind doing invasive pressure flow studies. We generally tend not to do them if they are straightforward bladder outlet obstruction, no other symptoms. You've got an enlarged prostate on clinical examination. You don't have to necessarily do them, but if they've got significant irritative symptoms which do not necessarily fit with your diagnosis of outlet obstruction, their flow rates are quite variable and irregular, if you suspect any neurological disease, then yes, you may have to do it before you proceed with surgical management. Again, there are certain indications which are recommended, which you will see now. Again, it's the gold standard because it will help you establish a diagnosis of bladder outlet obstruction, which will essentially be high bladder pressures with a poor flow. So that is what you will see if you've got bladder outlet obstruction. If you've got low pressures, low flow, that is detrusor failure. It's a lot more complex than that. Just giving you a nutshell. And we're not going to talk about urodynamics here in BPH. So if the simple questions, filling cystometry is what you measure when your bladder is filled. So you've got two phases, one where you slowly fill the bladder up, and then the other where you empty the bladder out. So where you empty the bladder out is where you check the voiding function, and when you're filling the bladder is when you check the storage function. And if there is detrusor overactivity during storage, without any underlying neurological problem, it's called idiopathic detrusor overactivity, which you can get commonly in someone who's got bladder outlet obstruction. And more often than not, all you have to do is treat the bladder outlet obstruction, and that symptoms usually disappear. If they've got an underlying neurological problem, the management is completely different. We're not going to discuss that now. Then you do the voiding phase, which is pressure flow studies, is assessment of the voiding phase. And it's not detrusor overactivity, it's to determine differentiate between bladder obstruction and detrusor failure, where the patient is not voiding because their bladder can't contract. So there are some specific scenarios where you generally do, who've had previous treatments and which it failed. We generally, first line would be, we do a flexible cystoscopy to see if there's any prostatic regrowth or any other reason why they're not passing urine. But so sometimes after a TWAP urine, you can get a stricture, which can be the reason why we get recurrence of these symptoms rather than the bladder. It's a lot more common than you think. Who cannot void at all because the bladder can't hold a lot of urine, who've got very high residual, again, it's a very soft indication just for doing pressure flow studies. But these are what's given in the textbook. So at least for the exam purposes, this is what you need to know. Practically, all of these are where you can suspect BOO, but you cannot confirm. And we need to do it before we offer any surgical management. If there is no clear evidence of bladder obstruction, then it helps to counsel patients that they may not see a significant improvement in their symptoms after they've had surgery. So also, before we subject a patient to pressure flow studies, we normally do an office flexible cystoscopy to see if we can actually rule out some other reasons which can explain the symptoms. Urethral stricture, this can sometimes cause detrusor overactivity or storage symptoms. Detrusor overactivity is a urodynamic diagnosis, so symptomatically can cause storage symptoms. And again, intravesical prostatic calculus can cause obstructive voiding symptoms as well. So what are the complications of BPH? They can get stones, they can get UTIs, they can get hematuria. Azotemia is when they very high bladder pressures, causes bilateral hydrourethral nephrosis, naturally retention of urine, but you will have to have retention of urine before you get azotemia. If chronic retention not treated over a very long time, bladder decompensation, sometimes you diverticulum, it's essentially a pop-off mechanism to save the bladder from becoming decompensated, and they can have incontinence of urine, predominantly nocturnal overflow incontinence. So can we say who can go into AUR? It's difficult to say. The older they are, the larger their prostate and the higher PSA levels, which is basically an indirect measure of the size of the prostate. If they've got a very high IPSS score and a very poor flow rate, these are the patients who can go into acute urinary retention. So what are the indications for surgery? So I say always try and remember the complications. The absolute indications for surgery are essentially all the complications of BPH. So get urinary retention, high pressure chronic retention, which can be decompensation of bladder or azotemia, LUTS refractory to medical treatment, and then all of the complications secondary to BPO, which can be UTI, hematuria, bladder stones, renal insufficiency, large bladder diverticulate. So anything that causes complications, all of these are indications of surgery. So just read one and then remember the rest. And the only thing you need to add on to that is high pressure chronic retention and LUTS refractory to medical treatment. And again, high pressure chronic retention, yes, theoretically you have to diagnose it with urodynamics, but more often than not, it's just a clinical diagnosis. If there's someone with presents with bilateral hydronephrosis and a creatinine of 6 or 10, which after you put a catheter in comes back to normal, that is high pressure chronic retention. You don't need urodynamics then to say that he's got bladder obstruction. And these patients cannot, that is the only absolute thing that you have to remember, they cannot be managed medically. That is an absolute contraindication. Once they develop renal dysfunction and bilateral hydronephrosis, they cannot be managed medically. In fact, they cannot even be managed by the minimally invasive surgical techniques, which we'll see later. So they need a procedure that's TURP or something more definitive, TURP or laser prostatectomies. So we have briefly touched about this, shown in the diagram. So the physiology essentially due to two reasons: increased smooth muscle tone and also generally increase in size of the prostate. These are the two reasons. As the prostate enlarges, you can also see that the length of the prostatic urethra becomes longer as well. You see prostates that are twice as long as normal ones, which is quite difficult to do surgery. And we've also seen about this where you need a curved catheter or what's called as a collated catheter to negotiate this. How will the bladder look? Bladder will be trabeculated, which means that if that's the bladder, trabeculation essentially means you can see the muscle bundles running. When you do a cystoscopy, and sometimes you can see diverticular when you're doing a cystoscopy. So these are signs of an obstructed bladder. So what is decompensation? Long-term bladder obstruction. It's just like any muscle, works less and less. It's like a big balloon that if you keep it inflated for a long time, it loses its tone. And once you after you let the air out, it's still floppy and enlarged. So essentially the same. So BPH, two ways to treat it: medical and surgical. We've seen the indications of surgery. Anyone who does not require surgery can be managed medically. So, and anyone who wishes not to remain on medical treatment, either because of side effects of medical treatment, they're not able to tolerate medical treatment, or they simply don't want to take medications, you can offer them surgical treatment. So refractory or intolerant to medical, so just remember the reasons for surgery. Anyone who can't have surgery will have medical treatment. This does not apply if someone's got a high pressure chronic retention, and if he can't have surgery, he essentially needs to be on a long-term catheter, or he can do if he's fit and quite switched on, then he can do what's intermittent self-catheterization, but the bladder needs to be drained artificially with the catheter to prevent a renal dysfunction to flare up again. So anyone who's got a good flow rate, mild symptoms, you don't need to start them on treatment, mainly because your tamsulosin, essentially if they've got a small prostate, your tamsulosin will not give them significant symptomatic relief. They're just going to be on the medication with no obvious advantages or this improvement in their symptoms. Make sure that you follow them up: assessment, flow rate, ultrasound, IPSS. Ultrasound is to essentially measure the post-word residual, and you can observe. And if they've got some storage symptoms and they've got a residual volume that is 200 ml is the cutoff, sorry. Residual volume that's less than 200 ml, you can give them anticholinergics. But beware, if you're giving them anticholinergics, you need to make sure that you monitor them more frequently. And if they have worsening voiding symptoms, then stop the anticholinergics. Anticholinergics are essentially oxybutynin, bladder relaxants, oxybutynin, tolterodine. There are so many different medications, solifenacin. So if you've decided that someone's got moderate LUTs on with IPSS, they've got a flow rate that's between 10 and 15. The residual volume is not too bad, it's between 40 and 100 ml. You decide that, and you've done a DRE, they've got some prostatic enlargement, maybe about 40 to 60. Let's say 40 to 60 grams, roughly, then what you do. So there's start them on medical management. So the first the mainstay of medical management is alpha-1 blockers, most commonly tamsulosin. You've got several medication which we'll see next, but that's what we most commonly start them on. And again, anyone who presents with acute urinary retention, you start them on alpha blockers. These work quickly, usually between 48 to 72 hours. You should be able to take do a trial without catheter. But anyone who goes into retention is definitely prone to develop retention again in the future. So medical management, most definitely everyone will get alpha blockers. Then you have to decide who is going to get 5-alpha reductase inhibitors. These are beneficial in people who have larger prostates. More than 40 grams or 40 cc is what is cutoff that's given in the urology books. And there's no hard and fast rule. If they've got a reasonably sized prostate, that means that the stromal component will also is, which is what these 5-alpha reductase inhibitors act on. There is a good amount of stromal component for these to act on and have an effect. Very small prostates, these are generally fibrotic, and their symptoms are mainly because of the increased alpha smooth muscle tone, and it's the alpha blockers that help with that. So to recap, medical management, alpha blockers is the mainstay. If you decide that someone needs to go on medical management for BPH, everyone gets alpha blockers. What medication, we'll see about that later. Then the decision is about 5-alpha reductase inhibitors, which is finasteride and dutasteride. Who gets them? If the prostate is more than 40 grams, yes, they will benefit from addition of 5-alpha reductase inhibitors. It's less than 40 grams, then no. Do they help in acute urinary retention? No, because these are slow acting. You can't, if they've got a large prostate, you can commence them on 5-alpha reductase inhibitors because they reduce the risk of developing AUR. In someone with BPH, they reduce the risk of that patient getting urinary retention in the future, but they're not useful in management of urinary retention themselves. I hope that is clear. So alpha-1A is we've seen this before, alpha-1A is the most common in the prostate, alpha-1D is the most common in detrusor. And so we are more concentrated. So alpha-1A blockers is what we try and use, and alpha-1A selective blockers are tamsulosin and silodosin. These are the two that are available now. But alpha-1 blockers work just the same. There is no trial, no evidence to suggest one medication is better than the other in terms of BPH, but naturally phenoxybenzimine, prazosin, indoramin, these are non-selective, non-subtype selective, and the side effects, especially in terms of hypotension, are a bit more pronounced for them to be used for just BPH. So doxazosin and terazosin, these are some MCQ points. These two drugs cause apoptosis in prostatic stromal cells, so they can reduce the volume, but not significantly. And they can also reduce blood pressure in hypertensive patients. So you might find doxazosine is some patients with BPH and hypertension remain just only on doxazosine because it can be used for both. Tamsulosin and silodosin, again, alpha-1A receptors are the reason for retrograde ejaculation because they decrease the bladder neck resistance. This is usually reversible. And more potent alpha-1 blockade, the more is the incidence of retrograde ejaculation, which means silodosin is more than tamsulosin. And silodosin acts rapidly, so you can even take a catheter out after 48 hours and it will have an effect. Alphazocin, it's not subtype pharmacologically selective, but clinically it is uroselective and it's preferred in younger patients because it causes less retrograde ejaculation. Naftopril, it is alpha-1D selective, and we found that is in the detrusor. It theoretically causes improvement in storage symptoms. This is not used regularly. I've not prescribed it. I've not seen anyone prescribe it. What we commonly use here in the UK is just tamsulosin. We don't even have silodosin, but you do get silodosin in India ads on it. It works fine. And as I said, there's nothing to suggest one is different to the other. It's just a question of availability and what you like to prescribe. Adverse effects, most commonly orthostatic or first dose hypotension. The advice we commonly give is to take the first dose at night after you're in bed to prevent orthostatic hypotension. And once they're established on the medication, then they can switch it over to the daytime. Again, alphazocin, because it's not pharmacologically uroselective, that's quite obvious that it has the maximum cardiovascular adverse effects. Again, dizziness and asthenia common to all. It is because of alpha blockade in the central nervous system. Just remember that. You don't need to. And they do not have any effects on sexual function. And intraoperative floppy iris syndrome seen on people who take tamsulosin or silodosin long term or any alpha blocker long term. It's essentially because the alpha-1A receptors in the iris get downregulated. I'm not sure why this is included. It may be because that is used. PDE5 inhibitors are now licensed for management of BPH. The way they act is by altering the blood supply to the pelvic organs through the pelvic plexus. So it's quite complex, but what it does is it causes an improvement in the IPSS scores, but there is no change in the flow rates, or at least no significant change in flow rates. So it alters the symptom profile, and it also improves sexual dysfunction secondary to LUTS. One that's licensed is tadalafil. Okay, but well, they do use the others as off-label. The only thing that can be given off as a licensed drug is tadalafil, and generally tend not to combine them with alpha blockers, at least to begin, unlike 5-alpha reductase inhibitors and alpha blockers, which you can start at the same time. We don't do that when you give them PDE5 inhibitors. Okay, so there's a small thing where there you go. Androgen regulation, which is, so the next class of drug is 5-alpha reductase inhibitors. The way they act is by testosterone to DHT. They block this conversion. The two types of this enzymes, type 1 and type 2. Type 1 is predominantly extraprostatic. Prostatic version is it's type 1. Finasteride, I'm sorry, it's just type 2. Dutasteride is both. It doesn't matter. They're both, again, like alpha blockers. They're both equally efficacious. You can use one or the other. It does not matter. What they do is they slowly reduce the volume of the prostate, and they can reduce the hematuria, episodes. They can reduce the risk of AUR, and they can reduce the PSA levels. And they do, yes, they do reduce risk of low risk prostate cancer, but increase the risk of high risk prostate cancer, which I'm not sure, I don't think they'll ask you about that. But what you need to know is they reduce the risk of AUR, they reduce the risk of hematuria, especially post prostatectomy, and they reduce the PSA, and the PSA levels decrease by about 50% in 6 months. And it takes about 6 months for them to give you any good therapeutic benefit. So you then go to surgery. We know, I won't go with that. It's not an indication for surgery, at least not what we've studied. The indications for surgery, just to recap, are failed trial without catheters 2 or more times, refractory, LUTS, or intolerant to medication, and complications. Complications can be high pressure chronic tension, UTIs, hematuria, diverticulum, stones. We're missing one more, but it's just bladder, and the other one is bladder decompensation, which is actually high pressure chronic retention. So let's delete all of this. This indications for surgery, which you can just scroll back. So I'm not sure what this means, but prophylactic antibiotics, we don't generally tend to give prophylactic antibiotics for whilst they're on catheters, but everyone comes in for surgery gets a dose of prophylactic antibiotic, irrespective of whether they have these risk factors or not. Men who've had an indwelling catheter, men who've had all of these, yes, we may give them additional antibiotics, but all of them, if you're doing a TURP, a single dose of pre-op antibiotic is absolutely mandatory. If they've been on a long-term catheter, if they've got prosthetic material or heart valves, then we will give them an extended course of antibiotics, but everyone gets a single dose of antibiotic prior to any prosthetic surgery, not just a TURP, can be TURP, HOLEP, can be just a simple urolift, the day case procedure. So there are 2 ways. Gold standard is TURP, or transurethral resection. Then these are the open surgical techniques. And then you have the laser prostatectomy techniques now, which can be either HOLEP, can be thulium, or it can be KTP, green light. It's called as green light laser. So TURP is still considered the gold standard. If someone's on anticoagulation that cannot be stopped, yes, we do laser. Some arterial bleeding, you need to coagulate. If it's venous use, put a catheter with some traction on. These are all post-op. I don't think you need to know the technique of TURP or how to do it. Again, these are all the arteries that you need to control, one at 5 and 7 o'clock on the floor. Arteries of Badenoch, and the one that's at 2 and 10 o'clock are the arteries are flock. And just know the name, retropubic prostatectomy is called Millen's, transvesical prostatectomy is called Freya's, and perineal prostatectomy is Young's, and this is mainly for cancer, although you can do it for BPH. And you have other transurethral needle ablation, transurethral microwave thermotherapy, radiofrequency ablation. All of these are investigational, and they're not as good as TURP. There are a few invasive techniques that we do, which I'll tell about later. So laser prostatectomy, holmium laser, 2140 nanometers. So it's a pulsed laser that you use for the workhorse in urology. You use it for stones, you use it for prostates. And what you basically do is an enucleation with the holmium laser. And it's the Millen's plane, but you do it with the beak of the cystoscope. So that's the whole KTP, it's 512 nanometers. It's also called green light laser. What we do here is vaporization. You shine the laser on the prostatic tissue, it just melts away. It's a slow process, it takes a bit of time, but it's very useful in patients who are on anticoagulation, where it just vaporizes and coagulates at the same time. So there's very less bleeding. Complications of surgery, essentially water intoxication, or what you call as TUR syndrome. It's more common with monopolar TURP, where you use glycine, which is a hypotonic irrigation fluid, which can get absorbed. With bipolar, we use normal saline. And the reason why we need to use glycine with monopolar is because we need to use a non-conductive solution. Because the way monopolar diathermy works is the current has to pass through the tissues and go onto an earth pad, and if you've got a conducting solution within the bladder, it just conducts off all the current and nothing reaches the tissues. Bipolar, on the other hand, the current goes through the loop and comes out through the other end of the loop, so you can use normal saline. And that's basically how you manage. It causes hyponatremia, fluid restriction, diuretics. You may need to supplement sodium with hypotonic saline if they're really unwell. How to reduce it? Bipolar TURP, essentially, procedure should be less than 90 minutes. Irrigation should be less than 100 centimeters. And should not be under pressure, but don't think TUR syndrome is something you need to be awfully concerned about, but it's more commonly seen with bipolar, with monopolar TURP, and it's commonly seen when the surgery is for prolonged duration. Other complications, erectile dysfunction, retrograde ejaculation, almost everyone will have it. Some do need blood transfusion, sepsis, especially common in people who are on a long-term catheter prior to surgery. And they can get UTIs post-procedure. So, as I said, I'll just highlight the other procedures. You could prostatic stents, which are not used nowadays. Prostate artery embolization, again, for unfit patients whose main complaint is hematuria. They're useful, not essentially as a treatment. Urolift, yes, for young patients, relatively small prostates who wish to maintain, do not wish to get adverse effects like retrograde ejaculation after TURP. And yes, you can give Urolift, and Resum is essentially the same. It's just water vapor that you shoot into the prostate, and then it just slowly coagulates and necrose. Prostate gets coagulated and necrosed as it over days. Again, microwave and RFA, something very similar. Not commonly done. What we use now is Urolift and Resume are the two procedures that they can both be done as office procedures under local anesthetic, and they do not have the sexual side effects of TURP. So these are the two that are done commonly. So just to recap what we've done so far. So low urinary tract symptoms in men. What you do an AUA symptom score. You do an examination including a DRE and urology. You do a serum PSA. If it says serum PSA, again, life expectancy is more than 10 years, and if diagnosed, it's a complex type discussion. Yeah, but you will not be wrong in saying you do a serum PSA. So what we need to do is, if they've got bothersome LUTs, you start them on drug treatment, and then if that fails, they will need surgical management. So managing nocturia is a completely different entity. It's the most difficult symptom to treat in BPH. If they've got bothersome nocturia, then you need to differentiate whether it's nocturnal polyuria or nocturia. So if it's nocturnal polyuria, yes, you need to reduce the fluid intake at night. We can consider treatments like desmopressing. But if it's just nocturia, then you can give them anticholinergics at night time. Again, it's exactly the same thing. This is basically, you diagnose them with bladder outlet obstruction, and it does say, you have to remember that this book is written in the US of A, where you get paid more if you operate, but anyone who's got BPH, it would be a crime not to offer sort of the ladder of management would be BPH. If they've got bothersome symptoms, you do medical treatment. And if they fail, cannot tolerate it for some reason, then yes, you proceed to surgery. It would, without trialing or having a discussion about medical management, it's not right. So that's what we discussed. Large gland, you do dual treatment, which is been shown to be better than just stopping them on single medication. If they've got a small gland, then just give an alpha blocker. When it says high PSA here, it doesn't necessarily mean that we suspect prostate cancer. PSA, even if it is less than 3.5, which is the normal cutoff, PSA that's 1.4 or 1.8 means they've got a considerably large gland. That's the reason why they have a higher PSA compared to someone who's got a PSA of 0.6 or 0.7. Someone who's got a PSA of 1.8 will have a larger prostate. That's another way of estimating the size of the prostate. And if someone's got such a high PSA, then they would benefit with some 5-alpha reductase inhibitors. And before you start patients on 5-alpha reductase inhibitors, it's good to do a baseline PSA. In small gland and a low PSA, which essentially means the same thing, we start them only on alpha blockers. If they've got some overactive symptoms, you don't always start both at the same time. We start alpha blockers or alpha blockers plus 5-alpha reductase inhibitors. Many times treating the obstruction helps with restored symptoms. If they still have persistent symptoms of overactivity, then yes, you can give them some antimuscarinics, but make sure that the residual urine is not more than 200 ml. If it is, then you can't give it. So if they fail medical management or if they have complications secondary to BPH, then you offer minimally invasive surgical treatment or surgery, depending upon what is suitable for that patient. I wouldn't worry about this bit. That is yeah. So the last component is bladder outlet obstruction due to bladder neck, which is not technically BPH. It's just bladder neck hypertrophy, which you see in young people, or bladder neck fibrosis, which is seen post radical prostatectomy or TURP. So management is completely different. If they've got simple bladder neck obstruction, the treatment would be transurethral incision of prostate, or TUIP, or also known as bladder neck incision. You need to be careful when doing this post-radical prostatectomy because you don't have the backing of the prostate, and if you do bladder neck incision if that's the bladder neck, you've got rectum right there, and if you do a bladder neck incision, they're going to go straight into the rectum. So you need to be very careful about doing a bladder neck incision with electricity in someone who's had prostatectomy. If you are doing a bladder neck incision, it needs to be anterior and not posterior. So first I saw is bladder neck hypertrophy, which is basically muscular hypertrophy of the internal sphincter. They do not respond very well to medical treatment. The first line is alpha adrenergic blockers, remember, right? Alphazocin. But most often they will need transurethral incision or transurethral bladder neck incision. In fibrosis, it's post-TURP. Post-TURP fibrosis is usually the risk factors are when you do aggressive bladder neck resection, there is undermining of bladder of the trigone during TURP. These are not what happens regularly, but if these happen, they are at higher risk for developing a bladder neck structure. So that is all about PPH. To recap, retention, you know what's acute, you know what's chronic. Management is the same. Catheter, if a catheter fails, flexible cystoscopy. If that fails, suprapubic catheter. High pressure chronic retention, no medical management, and no catheter removal till definitive surgery. Then coming to BPH itself, assessment is by IPSS, Euroflow and post-void residual, ultrasound, serum PSA is questionable, neurological exam and a DRE, prostate volume, you can estimate it with a DRE, but you can grossly underestimate it. A TRUS or an MRI would be more accurate. How do you manage? So urodynamic studies, you don't, not routine. It's only for recurrent people who have neurological problems or they have atypical symptoms. These are the ones who need urodynamic studies. You can read through the exact list, but that's the gist of it. Treatment broadly divided into two, medical and surgical. Just remember the indications for who've got bothersome symptoms. You will need to give some medical treatment. If they've got very mild symptoms that do not cause bother with a reasonably good flow rate, they don't even need to be started on medical treatment. Surgery, it's refractory retention, which means you've tried to remove catheter more than 2 times. High pressure chronic retention, failed or unsuccessful or intolerant to medical treatment. And the last is complications, which is recurrent UTIs, recurrent hematuria, renal dysfunction, bladder diverticulum, bladder stones. You can also include hydronephrosis there. Those are the indications for surgery. So if you're deciding to start someone on medical treatment, you need to have a rough estimate of the size of the prostate. Just a DRE is fine. You don't need to do a TRUS. It's just an approximation. So you use a DRE and PSA to estimate the estimate of prostate volume. 40 cc is the cutoff that we use, but different books say different things. If they've got a small prostate, think of alpha blockers, more than 40 cc, alpha blockers plus 5 alpha reductase inhibitors. If they've got OAB plus bladder lung obstruction, you can add anticholinergics if their PVR is less than 200 cc. The last is surgical options. They are all equally effective: TURP, HOLEP, KTP vaporization. I forgot to mention about thulium. It is another form of laser. It's 2030 nanometers. It's a continuous wave laser. It can be used to both vaporize and enucleate prostates. It's a newer laser, but essentially the surgical procedure is the same as that of HOLEP. So it's a newer. And TURP, you can have monopolar TURP or bipolar TURP, and all surgical managements, including open prostatectomy. We don't do this very frequently now. These are the different surgical options available. Last was about bladder neck hypertrophy. If it's primary, it's usually young men. And treatment is transurethral incision of prostate or bladder neck incision. If it's secondary, it's post-TURP or post-prostatectomy. Post-TURP, you do a BNI. Post-prostatectomy, you generally tend to do a dilation to avoid reduced risk of rectal injury and incontinence. But if you are doing a BNI, you should do it at 12 o'clock. So that is all about BPH. Hope this was useful. If you think we missed out on anything, let us know and we will try and either clear your doubts or do a little short video to address that. Thank you all.